Is there a way for me to like get rid of just have me in the corner? I feel like there must be. I've done it before. I just don't remember how to.
Okay, I think we're live.
Okay.
Hello, WebShadowers. Welcome back. We're so excited to be back. But before the session begins, we have a few announcements to make.
First off, we want to thank all of the wonderful physicians who generously donated their time to teaching us, along with all of you who participated last semester and made it possible for us to hold these sessions.
Additionally, we noticed that participants resubmitted their Google Forms along with false submissions. So to prevent this, we've updated our guidelines a little bit. You will now have to sign in into a Google account to fill out the Google Forms. This means that if you don't already have a Google account, please make one soon. They're very quick and easy to make.
Along with requiring sign-ins, we've added one more question to the Google Forms, making it a total of 4 questions and a summary. Therefore, you will have to score at least 3 out of 4 or 75% to receive credit for the session. Our summaries still require at least 3 sentences, but please ensure that you are writing well-written ones.
Regarding our certificates, every fall 2020 certificate for those who requested and earned a certificate have been sent out.
Our final announcement is that WebShadowers is adding a marketing position to our team. If you're interested in joining our team, please create a physician presentation post for us or send us a previous design you have made and message it to us on Instagram. We will be reviewing submissions throughout the week.
And as always, please remember that the Google form will be posted in the chat box at the end.
Now, with that all being said, today we have the pleasure of hosting Dr. Ramzan, who will be teaching us about family medicine. Dr. Ramzan, you may start whenever you're ready.
Okay, perfect. Thank you guys so much for having me. WebShadowers, I'm always really excited to present my love for family medicine. So I'm hoping that this presentation is really informative. I do want it to sort of be very interactive. So obviously, like if you guys have any questions or anything, I'd be happy to answer them as we go. And I'm kind of looking to see that we can make this as interactive as possible. So with that, let's get started. So here's just a little introduction about me. So I'm actually a family doctor that works in Toronto, Canada. I know that most of you are probably in the States, so I've kind of tried to adjust the presentation to kind of reflect a little bit more of the guidelines, et cetera, from the States so that it's a little bit more relevant to you guys. I've completed my bachelor's degree in biochemistry, and I basically did my medical school from the University of Ottawa. And then I decided to do my residency in family medicine in Toronto. And I've been working as a family doctor for the past 6 years. I work in a community clinic and mostly in a low socioeconomic area. So that kind of area presents with its own type of issues, but also like a really rewarding place to work. I also work as a medical director in a non-surgical cosmetic clinic. I don't talk very much about that in this presentation, but if you guys do want to ask me any of those questions, you're more than welcome to ask me if it's anything related to that as well too. So what I really wanted to do was kind of give you like a very like typical kind of like case or cases that are representative of what I would see as a family doctor. So almost like you'd be literally shadowing me and, you know, the type of patients you would see in my clinic. So the couple of things I really like about being a family doctor is I get to see people of all ages. When I was younger, I always wanted to be a pediatrician because I thought I loved kids, but now I came to kind of realize that I really like seeing everyone from, you know, like newborns all the way up to I have like a 101-year-old in my practice. So just like such a wide range of things that I see. When I was younger, I only used to see my family doctor just, you know, when I had a cough or a cold or something like that. So I just thought that that's what family doctors did. So it couldn't be any further from the truth. You see a lot of really interesting things. You're like the first person a lot of people come to talk to about issues. So you actually play a very important role. None of my 2 days are the same. So, you know, like I'll, you know, look at my schedule and kind of really not know what to expect. So it's kind of cool. So every day is like really unique. So if you like kind of like that uniqueness, then I think this kind of plays well to your strengths. It does for me. So usually I'm an appointment with a patient's about 10 to 15 minutes. So it's not like super long. And we'll kind of go through this as we kind of go through an example of like the time goes really fast and you kind of have a lot of things to like talk about. So, you have a minimal amount of time and you want to make the most of it. But what's kind of nice about being a family doctor is that you over time get to really know your patients. So, now that I've been in the same clinic for 6 years, I am able to really like know my patients pretty well. I think I just thought I'm going to try to see if I can answer some questions on the side, because someone asked, so what's the difference between a family doctor and internist? So we're both kind of like generalists, which means that we kind of deal with like a wide variety of issues. Someone who is in family medicine so I would have done medical school and then a 2-year residency training in family medicine in Canada. I know in the States, the family medicine residency is 3 years. And internist, you'll do a lot more in-depth studies of like a lot of the specialties, like cardiology, like about the heart, respirology, about the lungs, and nephrology, like about the kidney. So you're kind of like a fellow doctor, but like more of like just medical topics, whereas I will deal with sort of like patients who've got psychiatric illnesses. I'll deal with babies. I'll deal with like muscular problems. So I really basically deal with like anything. And I'm usually the first person most people see when they are coming into a clinic. And then I will, if I'm concerned about some issues, and I will refer people out. So in terms of things I like is the fact that I have a lot of ability to have great continuity of care. I really get to like know and talk to my patients, which I really enjoy. So for example, if I talk to someone and I'm not really sure like what to do with them, I can always just tell them to come back. Or like, if I'm really confused, I can refer them to a specialist, and then the specialist will see them. They'll write a letter back to me, so I know kind of like what happened. So I feel like I'm always kind of in the loop. Some people who are, for example, when you work in the emergency department, you will see a patient for whatever that emergency is, and then after that point, you may never see that patient again. So to me, like that loop doesn't get closed, but some people like acuity, like all the like excitement of the emerge. I kind of like being able to like see people on a regular basis and trying to like deal with their problems. And I think it's really cool that we do a lot of preventative care. So like helping people before they actually develop a lot of the main issues so that they don't have to actually, go to the hospital and deal with a lot of the complications. And other thing I find really cool is like you see someone like in your practice, she gets pregnant and then you start taking care of her kids. So it's like you really get to see like the families kind of like as they grow. Oh yeah, so someone's asked me about my email address. I'll kind of give that at the end. And some people are asking about building trust and relationship with patients. Yeah, and people are asking about how many people I see. Those are like honestly really, really good questions. So I'll try. I think I actually talk about quite a few of these things as I go through. Email address I'll have at the end. Relationship with patients is really like over time period, and I think every patient is really different. So one of the skills I think not a lot of people talk about is something called emotional intelligence, which is like, you can have a patient in front of you, but kind of like almost being able to read the patient and figure out like, which direction you think you're going to go with them. Some patients come in and they're like, okay, you tell them like, you need to take this medication. They'll say, perfect, I will take this medication. Then you'll have people who come and be like, I refuse to take this medication. And then you have to figure out why that is, what are the reasons, and like, can you kind of convince them to do it? So that's kind of the interesting part, really in all part of medicine. But what I like about family medicine is because you kind of develop a relationship with patients, you can kind of like convince them over time. Not always that you're able to do it on the first time. So sometimes it's a bit frustrating when you first start, but now I feel like a lot of my patients like really have a lot of trust in me, and they can really sort of rely on me to sort of give them the like best advice, and they're probably more likely to react positively to it. So I'll try to see if I can answer some questions as I kind of go. Oh yes, you guys are asking about universal healthcare. So, obviously I live in Canada, so a little bit different. So we basically have, you call it free healthcare, but essentially it's not really true. So we just pay higher taxes so that all of our health visits are covered. It's easy to refer, but the only issue is because of limited amount of specialists, sometimes it still takes a long time to see certain types of specialists. But the nice thing is I don't have to worry about whether someone can afford to like go see a specialist or get any type of treatment done or any type of like investigations or like tests done. So that's kind of cool. So anyways, let me just see if I can get through at least this case. So this is like a really typical person in my practice. So like this would be like, let's say Monday afternoon, 1 o'clock, I go in, it's Mr. Sunshine, he's 50 and he wants to come in and he's really just here to renew his blood pressure medication. Like he wants to like be in, be out kind of thing. And like, you know, he's got to get back to work type of thing. And he's totally fine. He's like comes in, he's like, I don't really have any symptoms. I just want to renew my medication. So, you know, what do you do? So every clinic is kind of obviously set up differently, but usually if we know someone is booked in to have their blood pressure taken, we will ask the nurse to take the blood pressure for us. So I kind of like walk in and I already know his blood pressure because it's been documented by the nurse. You know, obviously in some clinics you'll have to go do it yourself, but let's say this happened. So I know his blood pressure is 150 on 90. And so the question would be like, what would you want to do in terms of like, what questions would you ask him? And then what would you like look at in his chart? So to explain, like, you know, when a person comes in now in COVID, it's a little bit different. I'm kind of remote, but normally, let's say this is pre-COVID, I'd be like in my practice, I'd be across from this patient. I have my computer open in front of me. And obviously I have his chart. It's like an electronic database, which hopefully I've updated, and it basically has like, you know, his medical conditions and like his medications and his like blood tests and like everything he's done. So what would you find would be important for me to ask him, and what would be important for me to kind of like go over from his chart? So I'm going to see if there are, yeah. Ooh, a lot of really interesting questions about family medicine. Maybe I'll talk about family medicine right at the end. Okay, let me see if what you guys talk about. Yeah, so asking about diet, health changes, cardiovascular symptoms. Yeah, like, are you eating right? Has there been changes in your health? Those are really good questions. What's his usual blood pressure? Excellent. Does he have a family history of high blood pressure, like pre-existing conditions? Yeah, all these are really good. Yeah, I like this. Has the patient been taking medications as prescribed? Like, has he had any changes, stressors? Yeah, these are like really great. You guys are like, yeah, just check to see if there's anything unusual in terms of like changes in his blood pressure and stuff like that. Yeah, I think smoking, that's a good one. Caffeine, like you guys are like on it. Okay, cool. Weight, all this stuff, perfect. So to really like, I mean, your answers are still coming in, but really to kind of obviously explain or to understand like what to do next, you have to actually know a little bit about blood pressure. So blood pressure, high blood pressure is known as hypertension. We know this. So obviously high blood pressure is basically just the force of blood going through your blood vessels. And most of us will know, but there's a top number, there's a bottom number. The top number is basically as the blood is sort of like getting pumped through. And then the bottom number is kind of as the heart relaxes. So systolic is the top number, diastolic is the bottom number. And so if we look, you know, we have to understand, like, first of all, like what a normal and abnormal blood pressure is to like understand those numbers essentially. So 150 on 90, if we look on the chart, would be, you know, high blood pressure stage 2. So that means that his blood pressure is over 140 on 90, right? So obviously you have to know normals to understand what's abnormal. So interesting, in Canada, we don't have this like high blood pressure stage 1, which is that like 130 to 139. And it's just because I think in the States, you guys are being a little bit more careful in identifying people who are at higher risk of having high blood pressure. So it's almost like a pre-risk category where you want to like almost like capture people who are like going to get high blood pressure. So I don't think it's necessarily a bad thing, but it just means that you now have an even bigger pool of people who have high blood pressure. So we won't really talk much about it, but a hypertensive crisis is like when you have a really super high blood pressure, like over 180 on 120. And it's interesting, in my clinic, like I said, the demographics really low socioeconomics, people kind of like sometimes there are a lot of them are from certain populations where they naturally have very high blood pressures. I will often have people who have the blood pressure that high in my clinic and be perfectly fine. So you know, if someone does come in with a blood pressure that high, the first thing you have to ask is if they have symptoms, like, do they have a headache? Are they short of breath? Do they have chest pain? So you're basically trying to figure out if they're like imminently, because at that blood pressure, you're like imminently, like at that moment, at a really, really high risk of having a stroke or a heart attack. And that means you got to get to the hospital. But if the person is not symptomatic, you can really just focus on trying to get their blood pressure down. But it is really important to make sure their blood pressure does go down, because obviously then you just put them at high risk continuously. Yeah. Oh, yeah. So that's a great, so someone's asking like, what is considered hypotension, right? So that's a good question too. So technically, like for most people, so like I'll tell you, my resting blood pressure is about like 95 on like 55 or 60, something like that. So some people can have a really low resting blood pressure. As long as I'm not symptomatic, it's okay. So people, like I said, can have a low resting blood pressure. But let's say hypothetically, my blood pressure is like 140 on like 90, and I give someone like too many blood pressure medications, and now their blood pressure is like, you know, like 110 or like one, let's say like even less than 100, so like 95 on 50, like mine is, they're going to feel super dizzy because it's like a really big difference from their baseline. So in that case, when people are symptomatic from their blood pressure, maybe they could be treated too strongly or aggressively for their blood pressure. Okay, so like, you know, we kind of now we kind of understand like how blood pressure works. So like, what would you ask him? So I think you guys answered a lot of these things anyway. So you want to know, like, does he check his blood pressure at home? Does he take his medications regularly? Sometimes you ask some people to bring their medications with you. Salt intake is more of an important thing as like an overall, it will make your blood pressure go up. Caffeine is kind of more of an instantaneous or like temporary kind of increasing your blood pressure. So obviously if you have blood pressure, if you have caffeine right before you take your blood pressure, or if you exercise and then take your blood pressure, it's going to be high. You want to ask about weight gain. You want to ask him about like changes to his life, stressors, that kind of thing. So anyway, so this is kind of like what he tells you. So, you know, he's like, well, doc, you know, like I don't really check my blood pressure at home. Like I take my medications, but like, you know, every now and then I like miss a dose. So, you know, when people are talking about like getting to know your patient, so I can be like, okay, well, why? Like, what's your reasoning? And they'll be like, oh, you know, like there's a couple of days I'm like rushing to work in the morning. So now you can kind of focus on like your how to sort of like counsel him. So now you're already thinking, well, maybe like, can he like put an alarm on his phone? Like, can he put his medication like right beside like, you know, where his toothbrush is? So like, you know, he brushes his teeth and then like takes his medications right after. He didn't bring his pills with you. He tells you his diet is pretty balanced, but now you get to know he's Jamaican and his wife cooks spicy food. So maybe there's a lot of salt in what kind of the food that he takes. He had some coffee this morning and then he rushed to see you. Okay, so you're like, okay, that maybe makes your blood pressure a little bit higher. He hasn't gained weight. He's got a pretty stressful job. He doesn't really exercise. So let me see if I got anything. Yeah, socioeconomic stuff. Yeah, deals with some people can't afford medications. Some people, you know, so I have patients in my clinic who like they work like two jobs, and they're like, you know, like sometimes like almost like 12 to 16 hours a day. So like try to get them to like ask them to be like, oh, you should exercise or cook your own food. Forget it. Like there's no ability for them to be able to do this. So what we basically learned from, you know, Mr. Sunshine's answers is that, okay, so he, you know, is like, maybe his salt plays a diet, his caffeine probably played a diet, stress basically probably is playing a role in his blood pressure. And, you know, like if you checked his blood pressure at home, you could kind of look at the trends, right? So people often get anxious when they come to the clinic and have higher blood pressure. That's called white coat hypertension. So, I mean, also at home, like if you checked it regularly and it was like low or normal, I should say, and he checked it in the clinic and it's always high, I actually trust a lot of the values at home because that's kind of like when someone is like really relaxed. The only thing you can also do is you're kind of concerned, you can get them to bring their blood pressure machine into the clinic and compare it to the one that you have, just to make sure that their machine actually is working and giving like accurate readings. So, I mean, I think people kind of mention a lot of things, but like these are risk factors for high blood pressure. So, smoking, diabetes, obesity, cholesterol kind of stuff, high cholesterol, physical inactivity, having a family history of high blood pressure, certain ethnicity. So I have like I said, a lot of people from the Caribbean and a lot of people from Africa. And like I will see people like in their like late 20s to like 30s with like quite elevated high blood pressure, and sometimes they're like in really good shape too. So it's not always sometimes physically someone can look like they're in good shape and exercise but still have high blood pressure. So that's kind of a bit interesting. Obviously, as we age and if you're male, you're more likely to have high blood pressure. Yeah, so someone's asking about like if someone is nervous, so I'm actually going to kind of go over that. Yeah, good question. There's a lot of physiological stuff about like blood pressure. So, I didn't really put it in here, but you'll actually, if you put a chart of like people's blood pressure throughout the day, you'll actually see that blood pressure dips at nighttime. So it even like the thing with blood pressure, which, confuses a lot of people is that, they'll come and they're like, oh my gosh, doc, my blood pressure, like it's all over the place. It's like 120 and then it's like 140 and then it's like, this and that, right? And so, because it can vary from so many different things, it even depends on like how you measure the blood pressure. At the end of the day, what the question I'm trying to really answer is, what is this person's likely resting blood pressure? Like on a regular basis, when they're just kind of sitting and doing sort of like basic activities, what is their blood pressure? I know it's going to go up when they, when they exercise. I know temporarily go up when they have caffeine, etc. But at a resting blood pressure, what is their resting blood pressure? That's kind of the answer. So even if the blood pressure will vary up through the day, which it will naturally do that anyways, I want to get kind of an average. So that's what I'm really trying to get. So in terms of reviewing stuff from his chart, these are things we've already talked about as well too, which is like, was his blood pressure before? Is he like, does he always have high blood pressure? Is he diabetic? That kind of stuff. So, is he a smoker? Does he drink alcohol? Does he have any coronary arterial disease? That's CAD. Has he had a previous stroke? Because high blood pressure is one of the biggest risk factors for stroke. Does he have a family history? You want to look at what his medications are and kind of look when he had his like last blood test. So this is kind of like, kind of as you're talking to this patient, you're also kind of like, looking at his chart. So usually I've learned a little bit to multitask. So like, obviously like you want to be focused on the patient and like give them good eye contact, but as they're speaking and they're kind of like talking about certain things, I'll quickly just like glance at my chart and like look at a couple of things. So it's very easy for me to see like while he's doing that his blood pressure 4 months ago was like 128 on 78. I'm like, okay, that was pretty normal. So today it's high, and I was like, maybe it's from a couple of those things we mentioned, coming in, being like stress, like caffeine, all that kind of stuff. He's not taking his medications regularly. So he's not a diabetic. He does smoke. His alcohol intake's like 1 to 2 beers a night. So for most males, you want maximum 2 drinks per day, so to a maximum of like 10 to 14 drinks a week. So it's okay. He's kind of within that range. He hasn't had any heart attacks or strokes or any of these kind of thing. He's got some like family members who've had high blood pressure. He takes the medication for blood pressure, kind of irrelevant for you guys, but let's say he takes perindopril, and his last blood pressure was about a year ago. So blood work was about a year ago. So what are you going to do now with him? Yeah. Oh, and someone asked, like, what do you do if you have low blood pressure? So, technically, if someone has low blood pressure like me, but they're not symptomatic, you don't do anything about it. If someone is symptomatic, well, then you can do, so it depends on, on what setting it is, but, you can get them to take salt, the opposite of what you'd want someone with high blood pressure to do. Yeah, so someone was saying that like they would check early appointment and like people would not take their blood pressure medication in the morning, and so they'd always have high blood pressure in the morning. Yeah, that also happens as well too. Yeah, if someone's asking about which people generally have high blood pressure, yeah, it's definitely genetics for sure, plays a lot of role. Okay, I'm like, wait, yeah, he needs a blood test for sure. Yeah, he's a smoker, that kind of stuff. Yeah, for sure. Yeah. And someone's asking about how often to do blood tests and stuff like that. Yeah, all like really good questions. I'm sorry if I like also like miss some of them, because I'm just trying to obviously like keep on track. But if there's something that at the end that you guys want to ask me again, I'll try to go over any of those questions. So one of the things that we kind of missed was sort of like, I mean, I tried to make the case a little bit simpler in that, like, I'm going to just assume he has no symptoms, but in a real life setting, this person is going to come in and is going to be like, okay, I'm here for my blood pressure only, doc, but I'm going to ask you like 50 other questions. So he's going to come in and be like, oh, like my knee hurts, or like I have a headache, or like, oh, I need like, I don't know, something else. Like people always come in with like 6 problems that they have. So I'm simplifying things to like assume that he's like really just thought he would come in and come out and not have any other questions. But, it's usually a little bit more complicated in real life. So what I decided to do, and sometimes the nurses will already do this, is consider checking his blood pressure again. So the BP True is like, we have like a machine in our clinic that, so you can check blood pressure obviously manually. That's like when you put the cuff on and you like have the stethoscope, this way people see, or you can put them into the machine. The machines have their own, pros and cons kind of thing. You have to have the right like cuff size, which is similar to when you check it manually, but it'll actually check, like up to 6 readings and then kind of like take an average. So sometimes I'll actually, if I know someone is known to have high blood pressure, I'll actually get the nurse to put them onto the machine and like leave the room. You actually get them to sit like, their legs, both feet flat on the ground, not cross-legged, make sure they're almost like sitting 5-10 minutes in the room before, like almost in a quiet room. So this would actually be nice to do even before you saw this patient, but let's say we didn't. And I would probably just go off to go see someone else in the meantime and like let him get like a more proper reading when he's kind of a bit relaxed, and sort of see whether his blood pressure is still high at the time. So we get it back. It's a little bit better than before, which is kind of a normal thing to see. He maybe like sounds like, I don't know, when I last saw him, I don't really know what I did, but let's say we just do a quick exam just to make sure. I mean, he said he didn't have any symptoms, but we should probably just make sure, because sometimes people with high blood pressure, you can sometimes get little murmurs or like changes that you can kind of hear. We'll just make it really simple. Like everything is fine there. We'll check his height and his weight. We'll check his body mass index. So, it's 27. So he's like a bit overweight. So like, what are you kind of doing now? Yeah. So not necessarily, the checking it manually and through the machine, they kind of, like I said, have pros or cons. None is necessarily better than the other. Like obviously when you do it manually, it depends on the user, right? Like if you're super accurate, like you can get it down to the exact value, then you're good. Like some of the machines, like some people find it like tough putting their hand through, like even though it's the same cuff, but some people really just don't like the machines and they get a little bit higher values. So I think they have their pros and cons. Yeah, I mean, if you have like, usually the machine obviously is more accurate in the sense that, like when we measure it like manually, like I'm going to say like, oh, it's like about 145 on 85, because like, you're looking at the numbers as it kind of comes down, you can kind of tell, I won't explain, but it's like you'll see a number when you can see the top of the blood pressure and the bottom of the blood pressure, whereas like the machine will tell you, like they'll give you like this is 142 on like 83. So like obviously people have more like error than like machines do, right? Yeah, so like everyone's telling him to like, exercise more, cut back on his like sodium or sugar, salt intake. Yeah, so people talk about the smoking stuff, right? Yeah, for sure. Diet, exercise, yeah. Yeah. Lifestyle changes, right? Yeah, for sure. I think that's a really good. So that's if I trust BMI. I mean, like a BMI is just sort of like a rough, like a guideline to me. I'm not sure that I'm like using it as, so much. People of different ethnicities will also, like someone's like can be super athletic and have a really high BMI. So you have lots of athletes who have high BMI. So I kind of use it like in conjunction with everything else that I know. I mean, you can probably also see physically if this patient looks a bit overweight or not. Anyway, so now we're having this conversation with Mr. Sunshine. So you're like, okay, Mr. Sunshine, like your blood pressure is high. You try to see if you can like ask him about quitting smoking. So they say about 4% of people, if asked by their doctor, will quit smoking. So it kind of sounds like a really low number, but what's interesting is that it's actually a little bit higher than you think. And also just the thought process of bringing stuff up with people kind of gets them thinking about it. So technically you should be asking him at every visit, whether or not, like what his smoking has it changed, this kind of stuff. And honestly, through the time that I've seen people that I've sort of practiced and being in my practice, I've had lots of people quit smoking. And so sometimes it's like the conversation we have, sometimes they decide on a whim, but that's a really, really big, like one of the biggest risk factors for so many things. So it's definitely an important part. So obviously we're going to tell them you need to take your medications every day, figure out if there's a plan to kind of make that happen. You might depends on, his interest in this, but we have a dietitian in our clinic. So I can, and we have free access to a dietitian. So I can be like, listen, there's a dietitian, like, why don't you have a conversation? Because someone asked me about like time period of like talking to this patient, right? So yeah, like I have 10, 15 minutes to talk to this patient, right? Because then I have to go off and see someone else. I'm not seeing someone ask me about the number of people. I'm not seeing 70 to 100 people a day. Like most times I'm like seeing about like 30 people a day. So it depends on like what kind of clinic and setting and this kind of stuff. But like even 10, 15 minutes for that many people, it's like you don't really have as much time as you think. So the dietitian, at least in our clinic, like they have almost an hour to talk to the patient. So now you can have like a really in-depth conversation. And what they're really good at doing is like understanding the patient's diet based on his ethnicity and tailoring. Because like, look, in certain populations, we know that people are like more likely to eat certain things. So I'm South Asian. So like in our background, we eat a lot of rice. We eat a lot of like naan or bread or this kind of stuff. So if I tell someone like, oh, you need to like get rid of this stuff completely, they're going to be like, that's cool, doc, but I'm not going to do it. Right. So you have to like obviously tailor things, right, to what the person in front of you, right? So we learn all these things in books, like, oh, you need to do this, you need to do this, you do this. But at the end of the day, like you have to actually like individualize everything to the patient who's actually in front of you. So maybe it depends on our time. Is like we may come up with a plan about how we can kind of like exercise. Like we have like, things we have lots of handouts on things people can do. But the best thing would be to ask the question back to him, which is like, what do you think that you could do to kind of get yourself motivated to exercise? Like what would actually make you do it? Some people it's having a buddy to do it with. COVID's a little bit different now, but being able to go to the gym, like, what kind of activities does he like? Like maybe can you do something that's like right after work? Like, so having a discussion about practical answers rather than be like, cool, you should go exercise. And like, these are recommendations for exercise, right? So yes, you want him to do a blood test and you decide to increase his medications. And he comes back at you, and this is very common, and he's like, cool, doc, but I don't really think I need to worry about my blood pressure. Like I'm totally fine. I feel fine. I don't have any symptoms. I just wanted to come in and come out, and I don't know why you're giving me all these things to do. And I'm actually just thinking of stopping my medications. This happens. So you're like on this path, you have this like thought process and you're like, cool, this is what I'm going to do. And then the patient has their own ideas. So they want to go a completely different direction. So now what do you do with them, right? So I'm like way far in your, cultural differences. Yeah, this kind of stuff. Oh, someone's asking like, why would you bring up smoking if you aren't seeing them? Because really, I mean, ultimately you want everyone to stop smoking, right? Like cigarette smoking is like a huge risk factor for so many things. And so, sometimes if I'm seeing someone for something really quickly, I'll still bring it up. I'll be like, like I know last time we talked about smoking, blah, 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 but like, what do you think about it? And sometimes that simple conversation that's to do for something completely else ends up being a discussion on quitting smoking, and sometimes it actually does work. So family medicine is like very like you got to tailor yourself really around the day, and what kind of sometimes someone's in the mood and I just take the opportunity. So to answer, like to be able to tell Mr. Sunshine what to do, we have to kind of understand like why blood pressure is actually important or why high blood pressure is important, right? So we obviously know a lot of people don't have any, like they feel completely fine, right? And that's difficult for people to understand why they need to like worry about it. So if you think about it, like nearly half of the American population over the age of 20 has high blood pressure. that's huge, right? And so we know that it increases the risk of like stroke, heart attacks, can cause damage to the back of the eye. A lot of people don't know it can cause erectile dysfunction or sexual dysfunction, puts pressure on the kidneys. So the way I imagine it is like your kidneys are like filtering blood, right? And you know, so like it's like you're on this conveyor belt, right? And so like this is the job that the kidneys are doing, and then eventually like you're like telling them to like run super fast, right? Like you're increasing the speed of everything. Eventually like they're not going to be able to do their job really well, right? So now they slowly start to fail, but like you don't even really know that this person is like under. It's like when we deal with stress, sometimes we don't even know that we're stressed out, kind of thing. So you kind of like finally like work with him and come up with a plan. So he says, okay, fine, I'll take my medications daily because I get what you're telling me. My usual thing about my usual spiel on blood pressure is like, listen, I don't worry about you right now. I worry about you like 10, 20, 30 years down the road. And I'll say like, I know you maybe don't think this, but like, I think 50 is kind of young. And so you may have a lifespan of like so many more decades. And I don't want you to like end up with any of these complications that can like completely affect you for the rest of your life. So depending on the person, some people buy into it, some people don't. Some people, they buy into what I say like 2 years later, right? So sometimes it's frustrating. Some people never buy in. So you have to accept, right? Your job as a doctor is to like tell them why it's important, guide them, like encourage them, and tell them like what will happen if they don't. And then kind of you ultimately have to leave them. I'll tell people like I'm not your mom. I don't live with you. I can't force you to take anything. So at the end of the day, you have to make your decision, but I will guide you and help you through it. That's usually my way of working with people. I find it generally works. You have to tailor it to the person. Some people you have to be more forceful because you know that if you kind of just give them a little bit of push, they'll do it. And some people, you know, if you push them too much, they're just like never going to see you again, right? So anyways, he decides that he's okay to see the dietitian. He doesn't want to he's not at all convinced about quitting smoking. So you tried, but that didn't work at all. He wanted to do a blood test anyway, so that's good. He's gonna kind of think about exercising, but you know, he's not like super convinced about it. You talk to him about increasing his medications, but he's like, listen, like, I don't really want to do this. Like, sounds like you told me that like I can do stuff in my diet and lifestyle that might improve my blood pressure. So I would prefer to do that. And you say, okay, I mean, like your blood pressure is not super high. I'm okay with this. If his blood pressure was like 180, this would be a totally different conversation. I'd be like, no, this is like, I mean, again, I can't force him to do anything, but I would be a lot more pushy if his blood pressure was 180. If his blood pressure is where it is, like so around 140 something, I'm okay. I'll be like, okay, fine. I want to work with people because I want to like encourage them, and I want to sort of like feel like they are like being in charge of their own health, because I feel when people are like internally motivated by it, they're more likely to do things. So you tell him like let's touch base in a couple months, but you know, he agrees to get a blood pressure machine and check at home. So you tell him, look, if your blood pressure is going higher than what it is, you got to come and see me before, right? So you have a plan kind of in place. Yeah. People asking about my schedule. I can definitely talk about that later. Yeah, good question about his wife coming to the appointment. Yeah, I mean, the problem is that like, you know, like you have to look at like life, right? Like, so it depends on like if his wife has the ability to come to this appointment, but she could, you know, come to the dietitian appointment. That would be a great idea. Now with COVID, we're doing a lot of phone calls, so maybe she can be on the phone if she's the one who's doing all the cooking, that kind of stuff, right? Oh, someone's like, thank you for the patience. Yeah, I mean, listen, I've done this long enough now. I mean, I'm obviously still young and all that stuff, but I find that when you like work with people, you're more likely to get through with them. I feel like pushing people doesn't, like I said, to a certain extent, doesn't always work. Okay, anyway, so he basically comes back to your office 6 months later. Also very common, like you guys come up with a plan and patients just do what they want to do. So now it's 6 months later, and he's got a good reason. Like his job involves him working 12-hour shifts and he just couldn't come and see you. And now his blood pressure, so you find his blood test, you have the results, and now his blood pressure is 155 on 85. So like, what are you going to do now? So Yeah. Oh, can you just remind us? I think his last blood pressure was, but I think by the end of the thing it was like 145 on like 80 something. So it's definitely higher this time than it was last time. And if someone's asking about like, how do you deal with people who like refuse to do things? I have patients like this, a lot of them. All you can really do is like, I encourage them every time I talk about it in different ways. I try to find out what's the reasoning behind it. Some people are really fixed. You cannot change them. The main thing is you just document. You say like, I've had this discussion about, like what the risk factors are, like what people can get. And like, we've discussed it in great detail. And now, like, this person agrees not to take their medications, and we'll discuss with him again at the next visit. And you just bring it up, and it's frustrating. Sometimes eventually people change their mind. Sometimes if they get some symptoms or they become unwell, then they suddenly start to take your advice. And some people afterwards have come back and be like, oh, thank you for pushing me into doing X, Y, and Z. So you really have to play it a little bit by ear. Yeah, so yeah, basically someone's saying like, you want to do the follow-up questions. Yeah, like it's basically the same thing. Does he check his blood pressure, blah, 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 all this kind of stuff, right? So anyways, so we, so the update now is like he bought a machine, so that's good. So his blood pressure ranges from 135 over 85 to 145 on 90. So again, this kind of goes back to the conversation we had, which is like, why does it sort of like go up and down type of thing? And that's obviously because time of day, like, what was he doing at the time, that kind of stuff. Good thing. So we convinced him to take his medication every day. So that's good. He saw the dietitian, but then kind of like fell off the bandwagon. He didn't take any caffeine. So he learned from that. He still smokes. Okay, not surprised. He thinks he gained a couple of pounds. So now he was exercising, but like now he stopped. So like, what are you going to do? Yeah. Yeah. So if someone's asking about like cholesterol, this kind of stuff. Yeah. Yeah, it's a good question about like family resources. Yeah, give him. Yeah, I don't know. Yeah, I don't know if he doesn't necessarily need an antidepressant. It's like he's just a normal person who got busy in his life, and then like started to exercise and started to do something for his health, and then he like stopped. Like it's pretty normal. So not much to see. You recheck his blood pressure on the machine. It's kind of the same. It's kind of sort of the same thing. So I'm just gonna, so this is where you get his blood test. I'm just gonna like do the bare minimals. These are like the abnormal values. So you probably would check his cholesterol and other things as well too. Let's say his cholesterol's fine. So these are just like numbers, right? So you're like, okay, I don't know what this means, but his, GFR is 55, his ACR is 3, his A1C is 6.7, his fasting sugar is 130. I don't even know. So like performance goal, I have no idea what this even means. So what does this actually mean? So his GFR is like his filtration rate through his kidney. So your blood goes into the kidneys, it gets filtered, and then the anything that's like sort of like garbage that your body doesn't want to keep gets filtered out, goes into the urine, and everything else kind of is kept in the body. So if you see on the chart, like a GFR of 60 to 120 is normal, 15 to 60 is kind of means he's got some kidney disease, and less than 15 means that he's got kidney failure. So his GFR is like 55, right? So now we know that like because of the high blood pressure, like that same problem with like the filtering kind of thing, and like being on this conveyor belt and just all the pressure that due to the high blood pressure, it's putting a lot of pressure onto the kidneys. He's now starting to have kidney damage, right? And the albumin creatinine ratio is it's actually a urine test. And to simplify it really is like we talked about how the kidneys work. And so kidneys filter, and in a damaged kidney, because imagine like you're, again, this conveyor belt kind of thing, like you're not really able to like filter things properly, and like your quality control sucks, right? So now you're like leaking protein into your urine, and protein is really an important thing because your body wants to hold on to protein. So, and then when protein leaks, it's a sign of your kidneys being damaged. So like just in simple fact, this top part just means that now he kind of has like kidney damage, right? So cool. So we know, well, no, it's not cool, but that's not a good sign actually. So now because of his blood pressure, his kidneys are being overworked, and now they're not filtering as they should. And so now he's got like kidney damage, right? Yeah, so would you still use GFR for people who are generally active? I mean, you can still use it, but what's going to happen is that like it's, you know, you have to obviously take things with a grain of salt. And so again, there's actually like if someone is from like an African descent, you have to change, you have to adjust their GFR. There's like a whole calculation for that as well too. Yeah, someone said about like calculating race. Yeah, exactly right. So that's very true. So anyway, so yeah, you can also look whether the person has urine. Yeah, so like I'm trying, because honestly I'm trying to simplify things just because this is like there's so much to talk. Like I could talk about this topic forever just because these are like real life things that happen to people, and there's so much interesting things around all of these issues. But it's kind of what I was kind of trying to show is that like someone comes in for a really simple issue, and like, you know, this blood pressure thing suddenly leads to like a whole cascade of other things. So now he's got kidney damage, right? So, I mean, when people talk about chronic kidney disease, it just means that the kidney damage is being persistent for over 3 months. So technically, obviously, we'd have to compare his kidney function to before. You know, his kidney function might have been, let's say, let's say it was like 62, and now it's like 55. So now we know it's like he's kind of like gone into that like, you know, slight kidney damage area. But really, to say someone has kidney disease, you know, you have to look at it like over 3 months, you know, having to repeat. Lots of other things can cause, like, again, I don't have that much time to go over it, but like so many things can cause acute kidney damage. You know, so like certain medications can cause it. Like if someone has like a kidney stone and things get blocked up, that can cause like acute kidney damage. So there's like, they call them like pre-renal, renal, post-renal. So it's like before the kidneys, something that causes kidney damage, something directly affecting the kidneys, or something after the kidneys. But again, to like sort of simplify things, all I wanted to kind of show was the fact that this guy now has kidney damage. And so now this is like, you know, it's not quite a simple thing as like, oh, it's just high blood pressure without any issues. Like now he's starting to see like the initial damage, right? So risk factors for kidney disease is like diabetes, high blood pressure, heart attacks and stroke, obesity, family history, smoking cigarettes, being over 60. So he's got quite a few of these, right? So it's like not really super surprising. By far, the two most common things that I see are diabetes and high blood pressure as causing chronic kidney disease. I have like a ton of patients with chronic kidney disease. Actually, but very, very, very few of them are actually at the point of dialysis. So kind of, you know, most people think that if you've got kidney disease, it just means like now you're on dialysis and it's like the end of the world for you. You have a lot of people that are kind of in that like middle range. So between that, like, you know, I'd say almost like between like 30 and 60, where they've got some damage to their kidneys, but not super, super extensive amount. But you do have to then adjust people's medications as well too. So that means like every time someone comes in, you have to be like, oh, right, they have kidney disease, I can't prescribe them certain meds. So it doesn't, you know, it sounds, you know, maybe they feel fine, but like now we're starting to like really see sort of damage in the body that can have longstanding effects. Yeah, so like someone's asking about kidney disease. So like depends on like, you know, again, when someone has acute kidney disease or not. So some people, let's say like you get a really bad infection of your kidneys, you can get like your kidney can go kind of into failure. Let's say really bad. We're talking about like, you know, not a very common thing. But once if you deal with the infection and you get sort of like the person rehydrated, you can often get their kidney function to go back to normal. Sometimes, like, you know, it's like over time, if you've continuously damaged the kidneys over and over again over time, sometimes you never regain that function, right? And also, kidney function will naturally go down with age. So, you know, even with a little bit, like when I see like a GFR, like this like filtering rate of like 55 in someone who's like 90, I'm not quite as concerned about them. Whereas if I see someone who's got like a GFR 55 and they're like 30 something, I'm a lot more concerned about it, right? So, you know, you do this, you know, the other part of this blood test, which was like, you know, red flag was like this A1C and his sugar thing. So, question is like, what does that mean, right? So Basically, the A1C is a test. It's actually like a test that looks at your sugar values over the past 3 months. So what's interesting about it is my patients say this all the time. They're like, oh, but it's because I like had this like muffin in the morning, or I like, I don't know, like I had like, I don't know, like I went to like Tim Hortons, which we do, Tim Hortons is a very Canadian thing, but I went and got like a big muffin, like a donut or something in the morning, whatever, or I had a big coffee and sugar. But the A1C test is an average over 3 months. So it doesn't really matter what you had that day, right? But, assuming like, I said that was his fasting blood sugar. So let's say he like listened to our instructions and actually did a fasting sugar test, right? To diagnose diabetes, you need to have 2 values of the sugar values in the diabetic range, depending on different tests that you can do. So the A1C is the sugar test over the last 3 months. Fasting sugar test is like they just take your blood test, and that's the sugar value you have at the day when you are fasting. A glucose tolerance test is basically like you go to the lab and you drink this, I've never had it, but like a gross sugary drink, and then you basically see like after like 2 hours, like it's actually after 1 hour, and then they take your blood test, and after 2 hours they take your blood test, and they try to see whether or not like how high your sugar goes up, and it can also be used to diagnose diabetes. So again, I'm like, you can have a whole conversation on diabetes in its own, but it was just sort of more to sort of like kind of show the point. These are real life examples of people that I see. And so, simple kind of person came in for like one thing, and now he's starting to have kidney damage, and now he's diabetes, right? So based on the criteria, right? Like his fasting A1C is 6.7 and fasting sugar is 130, right? So that's like that's in like basically in the diabetic range, right? Yeah, so yeah, I don't know if there's anything that's yeah, I don't know if there's anything that's really interesting. Yeah, it's just someone's asking about like kidney damage. Yeah, I mean, like most people will end up on dialysis. Like I said, I actually have a ton of patients who are diabetic and a ton of patients who have chronic kidney disease, and very few of them who are actually on dialysis. So it actually shows you that if you actually control your diabetes really well, you can actually be a well-controlled diabetic, even with medications or without medications, or with or without insulin. So like I'm really like I'm a little bit stricter on my diabetic and my blood pressure patients, just because I know like how much I can really affect their life. So basically, to explain diabetes, we're talking also about like type 2 diabetes, right? Type 1 diabetes is what people get when they're younger. So and this is this diagram shows type 1 diabetes, which is basically the pancreas is unable to make insulin. But in the example that we're talking about in this patient, we're clearly talking about type 2 diabetes, right? So type 2 diabetes is usually basically related to like insulin resistance. So basically when there's high sugars in the it's sort of like circulating in the blood, insulin basically allows those insulin is released and like sugar is brought into the cell, so the blood level of your sugar kind of goes down. In type 1, it's like you just don't have the ability to make insulin, so like you just can't bring that sugar into the cell, so your sugars just stay high, right? And whereas type 2 diabetes, it usually just means that the body isn't able to use the insulin receptors as well, so the sugar is it's just not as good at doing its job, right? So, I mean, just very briefly, like these are risk factors for diabetes, right? So a lot of these are all the kind of same things. They're like family history, being over age of 45, like certain ethnicities, not being active, smoking, high cholesterol, high blood pressure. They're like everything is all related. So this, even from the beginning, you would call this patient a metabolic patient, right? So he's got a lot of these risk factors to develop all these things. So in some ways, you're kind of not really surprised that like he ends up having kind of like all these issues, right? So the main thing is now, so he's obviously going to like start to ask you about diabetes. You're going to have to explain it to him. And, these are like the main things that you're going to want to like talk to him about, which is, like if you have untreated diabetes, you can have, they call them microvascular complications. So like they're to the small blood vessels. So that's the eyes. So it can result in like damage to the eyes and blindness, to the kidneys. So it's microvascular, like damage to the blood vessels involving the kidneys. And then peripheral neuropathy just means like damage to the little nerves. Usually it's called hand and glove distribution. So it means it usually affects like the tips of people's fingers and the tips of people's toes. And then and obviously people then as a result, like I have patients who've like stepped on things, but they have like no sensation on the bottom of their feet, and they've like burnt their feet, or like they've like stepped on nails, that kind of stuff. So I mean, like, it's no joke kind of thing. And then issues related to macrovascular basically just means like to the bigger blood vessels. So that would be in the heart and in the brain. So that'd be like stroke and heart attack. Cool. So going back to the example is basically, so now we know he's like diabetic. And so again, like now we have to like go back to this patient, and remember we're talking about like, he's like, like we have like 10-15 minutes. So like he came in again, just for like a simple thing, just to review, and we haven't seen him for like 6 months. And so we have a lot of things to deal with, right? So like, there's like his blood pressure problem, his like smoking problem, he's like overweight, and like now he's kidney problems, and he's got diabetes. Like really, it's like, geez, like it's a lot to deal with. So like, how do you actually deal with this in a real life setting? So this is a very common thing for me to do on a regular basis. So at least blood pressure, we've kind of talked to him about, right? We could try to see if we can get him back onto like a good regimen and that kind of stuff. Sometimes when people know they're diabetic, they sometimes kind of is a little bit of a wake up call. So that sometimes is interesting. In terms of like, so if we deal with one issue at a time, right? The blood pressure, I think now we've kind of like come to the conclusion, like his blood pressure is like, still high, and we really got to like focus on this because now it's starting to have damage. It started to have damage his kidneys, right? And again, a lot of people get really freaked out when you say that they have damage to their kidneys, or like sort of like early kidney disease. So you're like, so now he kind of is like, okay, I kind of agree to your recommendation on the medications. So the second issue is now he's got kidney damage, right? So the main big thing for his kidney damage is we need to get his blood pressure down, and we need to get his sugar down, right? Those are like the two main big things. Then the smoking. But like in terms of what he can do, obviously it would be the same things that you would say to be geared towards his blood pressure issue and also his sugar issue, right? And he needs to be on a kidney protecting medication. And just to make it simple, I picked this medication, which is it's called an ACE inhibitor. Again, whole discussion on itself, but this is a medication that is a kidney protecting medication. So at least it will kind of prevent him from having future damage to his kidneys. So, in terms of his diabetes, like his sugars are like not horribly high. Again, we have to kind of make the discussion about like whether to start medications or not, or like whether he can kind of motivate himself with diet and this kind of stuff. He seems to be, again, like really motivated, and he's like really adamant about not starting his medication, starting anything else for that. He already agreed to the blood pressure. So sometimes like two things people don't agree with. So you're like, okay, we'll work on this. He needs an eye exam and a foot exam because of his diabetes now, and you're going to see him much more often. You're going to say like, you have to come and see me at least 3 months. And this is also going to be really helpful, connecting him with a diabetic education team where they have a nurse and dietitian. When you tell someone about diabetes, like imagine someone coming to you and is like, these are like 60 things that are wrong with you. You're going to remember like very minimal amount of the things that someone tells you in this like appointment, right? I'm trying to tell you like all the things you can do. So you're gonna have to either bring him back in to have this discussion again, or you're gonna have him like see someone who can sit him down to really explain to him, maybe his wife as well, like what the implications of this, and so that he's well educated on what this means. So you tell him to come back and see you like in a month, basically, mostly just to sort of see like, how he's sort of doing. So just because we're running out a little bit of time, I'm going to rush a little bit, but basically, let's say he comes back to your clinic. So he saw the diabetic team. So like now it's like, okay, he kind of understands a little bit about diabetes. He got his eye and foot exam done. Good for him. He kind of is a little bit more knowledgeable. He's changed his diet and all this stuff, right? And so he started to exercise. Not bad, he's 10-15 minutes every day, so every 3 days. And now his blood pressure is normal. So you're like, okay, cool. you know, it sounds like he's kind of come onto track a little bit. So now you're like really encouraged by this, right? So, you know, it sounds like the blood pressure medication worked, and a little bit of maybe his diet and lifestyle stuff. And, you know, like this is where I take a moment to like encourage them and, okay, you know, it's good. I'm glad that you did this. I'm glad we're here. I'm glad, you know, you've done these things. And, you know, the A1C is that sugar test every 3 months, right? So you want to, again, like check his blood test again every 3 months. And just sort of like, let's say he comes back 2 months later, right? And he's done his blood test, and like now his blood pressure is 118. Okay, so now you're a little bit more comfortable. His blood pressure consistently is pretty good. He's now focused himself on like trying to lose weight. He's still smoking, which is common. So now you're thinking like, yes, yeah, everyone's like, yay, yay. Yeah. So you're like, finally, after like struggling with him forever, you're like, okay, I mean, we talk about this is like how many months of this kind of struggle, right? So you repeat his blood test, right? And so his GFR is like 54, his ACR is 2. It's basically the same thing, but it's a little bit better, right? The reality is like, you know, again, we don't really know, but he probably has had high blood pressure for a long period of time. And it's really unlikely, and of course now his diabetes, so it's unlikely his like kidney test is gonna like improve significantly. It might, but you know, at some point you kind of have to realize that you probably are just trying to maintain his kidney function, right? You want it to just sort of stay the same. And so almost staying the same is kind of like a victory in some ways, right? So he's leaking a little bit less protein, so that's good. His sugar is a little bit better. So like, okay. And again, this whole topic wasn't just, I didn't want to go, diabetes is a whole topic on its own, right? So let's say like, you know, we got him to kind of like get to sort of where we wanted without taking medications, right? So we're like, yay, great. You like, you know, we're like, you know, you got to keep on doing what you're doing. And then like, now we can maybe finally talk to him a little bit about the smoking piece. Cause like, you know, again, when, like if someone comes at you with 50 problems, like you're just, if it was me, if someone told me I have to fix 60 things about myself, I'm not going to do any of those things because it's too much. So you have to like bite-size things so that people can sort of like miniature goals, right? Like to sort of get yourself on track kind of thing. So sort of going to conclude, but, you know, obviously if there's any questions, we'll go through them. But basically, just to show this is a real guy comes in my clinic, and he comes in for something simple. You think it's going to be a quick appointment. You know, you just like, you go and you say like, here's your medication, goodbye, kind of thing. And obviously like you see, like he's not very compliant in the beginning. He's sort of like, meh, whatever, right? All the time. I have people who like, you know, they'll come, they'll be in great shape, and then they just like stop all their meds just to see what happens, right? And then of course everything's haywire, and then you have to like remind them again why it's important for them to sort of like do certain things, or like, you know, if they are trying to change their medications, to actually have a conversation with you. So like in this case, what we didn't realize, what we don't like, what Mr. Sunshine doesn't really know is that we did a lot of preventative medicine right here, right? Like we don't really 100% know, but we probably, in kind of making him sort of like really adamant about taking care of his health, like probably reduced a lot of his complications. Still don't know. I mean, he can still get all those things, right? He still has to continue like being super compliant. But, you know, like, again, if his blood pressure had stayed high, he would have been much higher risk of like all those complications, right? We sometimes don't talk that much about using allied health, but like, man, are they important. Like our diabetic team is like super key for me. Like they do a lot of the like baseline stuff. So like I can kind of focus on maybe like just adjusting the medication. I just, you know, it's hard because you have such little amount of time, right? So they can really spend a lot of time talking to patients about like the like the minutia, like, you know, the cultural differences, like how do they like actually implement in real life? Like, you know, they can often get your, you know, like actually print out the blood test for the patient. So it makes it really much easier for me, right? The other thing we learned is that we've got to be really like, you know, again, we can't force someone to come to the appointments, but like it almost sometimes helpful to book something before they leave. So like, it's like, they know that they're booked, right? So, and then we also realized that he had like all these things and he didn't even know about it. Like we didn't even know that he had kidney problems and diabetes and all this stuff. He was just running through his life, right? He didn't even know. And so, we talk a lot about medication. Again, I have people who are diabetic and high blood pressure, and they're so varied, right? Sometimes, like I said, due to genetic issues, like I can't help but put people on medication. So if it was up to me, I would choose to put no one on medication if I knew that I could be convinced that their blood pressure would be, or their sugars would be in good range, without being on meds. But life is life, right? Like people are not going to always be able to exercise. Like sometimes genetics means that they just have high blood pressure, that kind of thing. So, but if we can really encourage them to make changes, some people make amazing, like I've seen some really incredible transformations. But it obviously takes time, right? They're not overnight changes. Some people just would rather take a pill. And so if you know that there's like, you're gonna help someone better with just giving them a pill, sometimes you do that just because the alternative is that if they're not treated, they're going to be in much worse state, right? We talked a lot about the social factors, that kind of stuff, and really tailoring it to the patient that's like in front of you. That's why, like, again, when someone sees a specialist, right, like that specialist doesn't always know the patient, right, unless they've seen them on more than one occasion. I really get to know my patient, so I know after a while, like, who I'm going to convince, who I'm not going to convince, how I'm going to convince this person. I'm not a genius. I've come to realize like who and what kind of like works, and so that just comes with like clinical practice. It's not really anything. Sometimes people are just have a good intuition about these things, but like a specialist job is like they're like some people are like some doctors are really focused on like these are the guidelines. We must get someone at this like this blood pressure or this thing, and they don't really care how they get that patient to it. But I really try to work with someone because I want someone to then like have a really good relationship with me. And so then they also come to tell me like the truth, like when they stop their meds, when they're not doing things correctly, like people will be, for the most part, relatively honest. Though I know people are never always honest, right? Everyone wants their doctor to know like everything, right? And basically through this one example, you guys kind of like, we actually talked about a lot of issues where like you didn't really think that one person could kind of give us so much things to talk about. So, I mean, in terms of like, I was asked to just sort of like put like a little advice. So I remember for myself, like, I found that like anyone, so for me, when I'm sort of teaching students, I find that anyone who's willing to learn, I feel like I'm willing to teach them. And I also find if people are kind, I feel like people will find a way to help you out. Number of times I've been helped by like nurses and other people, and I had no idea what I was doing, has been huge during my process. So I feel like kindness is one of the things that has really gotten me quite far. And so that's kind of like my advice. So, I mean, that's really the end of my presentation. I'm going to try to see if there's things that people want to like ask me, that kind of thing. My email address is there. My Instagram handle is there. So you guys are more than welcome to like message me. Yeah. Let me see if there's anything. Yeah. So it's like, how do you manage to like connect in a meaning? So the thing is like, it's hard to connect that much in 15 minutes. Is really with time that you really connect with people, right? Like in that time period, like sometimes when people come in for really short appointments, I get to know them in other ways too. Like you get to know like their family and like, sometimes you take care of like them and their aunt and their uncle and like everyone, right? So you even like some of those, oh, how's your weekend? Like, how are things? This kind of stuff. So like you really build a rapport with people. Obviously, it helps if you're like friendly and engaged with people. Like if you come in and you're like really like a not really easy to communicate with, then people don't communicate well with you, right? So I think it's a lot about your communication style. Someone asked me way before about like how things are different like with COVID. So right now I'm just doing phone calls, right? So a little bit different, like visual cues are so important. I have people who don't speak English, so like they either bring a translator in with them or they like write down stuff. And so like now I'm like, I don't like some of these things become really challenging now, right? Like they can't communicate well with me over the phone, so sometimes I'm like really have to like bring them into the clinic, right? Even though we're told to really bring very minimal amount of people in. So it's like really challenging and sort of to deal with. But there's this whole thing about family medicine is like, obviously I really like it, so I'm really passionate about it. Yeah, it's like I don't know if there's anything else that someone really has, I'm getting a lot of thank yous, so I appreciate that part. But is there anything else that any of you really want to ask? Like if there was any like burning questions, I can like stay on for a little bit and just, you know, see if anyone has any questions. Because obviously like there was a lot of stuff we talked about, and so I may have like glanced over. Yeah, someone said about the residency. So like in Canada, the residency is 2 years, but in the States it's 3 years. So it's a little bit of a difference. Someone's asking about like telehealth versus input. Honestly, like I like both in different ways. Like sometimes you can deal with certain things much faster on the telephone. Someone really is in for something really simple, but you miss a lot of things when you call people, right? Like I wouldn't know like their blood pressure unless I asked them, right? So this case would probably be like, you know, like you wouldn't even get to this case if this was telemedicine, right? Because I would just renew the person's medication. I'd ask them like, hey, do you check your blood pressure? I wouldn't have even known half these things. So, you know, probably with telemedicine, we're probably going to miss certain things. But, you know, as someone who enjoys people, I like seeing people, obviously. But not gonna lie, sometimes being in your pajamas and talking to people is kind of cool too. So I like that part. Work-life balance. Oh, that was a good question. So someone asked me about my schedule and stuff. So I actually only work doing family medicine about 3 days a week, right? So mostly I'm like 9 to 4 when I was like going in like COVID, like prior to COVID. So it seems kind of very minimal when you sort of think about it. When I first started, I was like, you know, 5 to 6 days. 6 was a bit crazy, but 5 days, right? And it's a lot. I didn't talk about it at all in this presentation, but I do a lot of mental health. And so that can be really draining. People tell you a lot of like, you know, really deep stuff, and sometimes it's quite involved. And so in those 10, 15, sometimes I have to take like 20, 25, 30 minutes to like have a conversation with someone. You can't leave some of those conversations with people in like crises or things. So yeah, so sometimes that can be a bit challenging. But I mean, I'm usually not working on Mondays. I do stuff remotely. So you can consider it. But there's one thing I didn't talk about at there's a lot of paperwork and stuff. So while, like, for example, you order a test, like when you are reading the test or like going over the results, it's not like, it's like kind of like on your own time, right? So this is like after you spent the day talking to people, right? So you're busy like 9 to 4. And then so like, when are you doing these? Like sometimes in the evening I'm doing them, or sometimes in between patients. Sometimes you get a little bit of ahead. And so you'll actually like check stuff up and renew prescriptions and that kind of stuff. But overall, like, I think the thing about family medicine is you can really tailor it. So you can work excessively if you like, you can work less if you like. I mean, obviously it depends on like, kind of what you're looking for. I hope it's okay. I'm just like babbling on for longer. I mean, if some people obviously have to go, you guys can obviously go, but someone's asking about like fellowships opportunity. Family medicine is so interesting because like I said, I didn't really know what I wanted to do. And I kind of was really confused for most of my medical school in terms of like what to do. With fellowships, I mean, you can do a fellowship in Emerge. I like hate to sort of make general because I don't exactly know in the States, but I know I can kind of definitely talk about it in Canada. Like you can do a fellowship in Emerge, you can do it in obstetrics, delivering babies. You can do a little bit in palliative care, so it's like the end of care life. You can do it in anesthesiology, so it's like, like when you go and get surgery, that kind of thing. You can be a surgical assist. You can do what I do on the side. I do cosmetics, like usually 1 to 2 days a week. What I like, you can do like procedural stuff. Like you can do so many things, like injections. I do injections into joints. And again, like I think there's so many cool things you can do. Some fellowships are a lot more difficult to get in. Everyone really wants to do like family medicine plus a year of emergency medicine. So that's kind of a little bit more, I guess there's a lot more people who are more interested in that. Emerge is not last on my list of things. I didn't like the acuity kind of thing. Someone talked about practicing privately. Yeah, so maybe I didn't clarify that really quick. So I basically work, so like in Canada, like where all of us are like technically publicly, I'd say like almost all of us are like publicly funded. So what I meant by private clinic, I just meant like a clinic that's not associated with a hospital or anything like that, but we're all like I get paid by the government essentially. We have like 8 doctors in our clinic, so I'm not like a sole practitioner. I like working in a kind of group environment in case you're away or that kind of thing. People can kind of help to take over, which is really nice. Otherwise, if you're a sole practitioner, like when you try to take time off, like you have to shut your clinic down, right? Which is much more difficult. Whereas obviously people's medical problems never stop, right? It's not like, you know, you choose to take a day off and your patients are like, cool, I'll take a day off, my problems too. Yeah, I mean, the socioeconomic area is sort of like really difficult, but why did I choose to be an MD or that kind of thing? So it's a good question. I think I always really liked science, and nursing it was also like very similar. I guess it was just like a lot of the decision-making process and like the analytical things that I really liked on top of that. Yeah, someone's asking if I speak Urdu and Hindi. I do actually. So I actually work once a month at a free medical clinic, which is like funny because we have free medical care, but these are people who are like visitors or that kind of stuff who don't have a health card. So you have to have a health card here to be able to get free care. And most of the people are like immigrants who speak the same language as me. So all the time, for sure. Having a different language to speak makes a big difference. Why did I, so funny, someone asked me, why did I practice in this kind of area? Actually had no intention to. I was looking for like a temporary placement for like 2 months, just because I needed, like, I had another job lined up, and I went here and I was like, this is probably not where I see myself working. And then, I don't know, just fell in love with it. It was weird. You know, you teach people really simple things and they're very like, they're very indebted to you. Like Tylenol for pain. I feel like that, I don't know, I just thought that was a normal thing for people to know, but you know, a lot of people don't know that's what you can do it or how to use it. Or so I feel like I really make a big difference here. I worked in a affluential area. Sometimes found people a bit annoying because like they just had their own ideologies and like didn't really want to listen. And here, people are really like a lot more likely to like listen. They sometimes go off on their own tangents, which they just don't know any better, but I liked it better. So why I chose, someone asked me about family medicine versus peds. Honestly, there's two reasons. One, I realized I liked older people too. They're really cool. I think they tell amazing stories. And you learn so much from them as well too. And also, I didn't really want to see a lot of sick kids, so I mostly just see like really happy babies, like, you know, like well baby checks as they're like kind of going older. I don't even do the needles; the nurses do the needles. I get to like basically play with kids and then give them back to their parents. So I really like that. Like I said, I think I usually see like 25 to 30 people a day. Again, it's sort of also I didn't really explain very much, but I'm in a very different practice style where I can like there's different ways you can get paid, but essentially the way the practice I'm working in allows me to have more time to do like more preventative stuff. There's some clinics that are just like walk-in clinics where you're just really dealing with like you know, urgent issues, like someone has a bladder infection, like boom, you treat them really fast or like kind of thing. So those kind of walk-in clinics, like I probably could see like 50, 70 people a day if someone came in with like 2-minute problems, right? I just don't really like that type of medicine. So that's why I didn't really want to practice in a walk-in clinic. I like, you can probably tell I talk a lot. So I like to get to know someone rather than just be like, cool, here's a prescription, buy, right? I think it really just depends on your personality type of thing. Burnout. Yeah, I had burnout at Christmas time. You have to remember to take time off, which I didn't. Good question about addressing patients, reducing pill burden. Happens all the time. People are trying to like, you know, some people come in, they're already on like 10 medications, right? And you're like, okay. I mean, one thing we should do with all of our patients is look at what they call it polypharmacy, when people are all on too many medications. And we should actually be like, again, life is just super busy. So like, you know, you can see like how much you have to deal with in like 15 minutes. But, you know, if someone has a smaller appointment, I sometimes will actually like look through their meds and see if we can adjust. I've had people that have made such improvements to their diabetes through like diet and stuff like that. I've taken away meds. Doesn't happen very often, but can. So yeah. So I realized I wanted to do family medicine in my between my third and fourth year, I actually almost wanted to become a dermatologist too. Hence why, like, when people tell you that you need to know what you want to do, forget it. It's not true. I had people who in my class who were like, I want to be this surgeon, and they talked about it for like years and years. Well, the 3 years that we were there, and they changed their mind last minute. So forget it. Like, I think that you should just be open to whatever kind of finds your way. I think something will find your way. This found me. Like, I don't think I wanted to be a specialist. I didn't want to be a family doctor. I thought family doctors have to know too many things about things. And so I was like, this is not going to be my, this is not going to be my profession. So I was a bit surprised. Yeah. Someone asked me, did I choose B? So like, yeah, so I mean, in family medicine, you see kids as well too, right? Or you can choose to see kids, right? So I see kids as well in my family practice. So to me, it's cool. My schedule, like I said, at the Mondays, I'm not usually working. I'll do paperwork. Tuesday, Wednesdays, and Fridays, I'm working in the clinic, usually pre-COVID 9 to 4. Then I do some like paperwork when I come home. And I do my cosmetic injecting usually on Thursdays, and I do like some remote consulting for that too. I'm a little bit excessive worker, so I will take on a little bit more, but I could really just not work as much. So someone asked me about MD over DO. So we don't actually have DOs in Canada, so that kind of made my decision a little bit easier. I'll be honest, I only through Instagram have I learned a little bit more about DOs and that kind of stuff, but I would not be the best person to ask about the differences between the two. Someone's like, when do you discard what people are saying? I mean, sometimes you have to see, the thing is, like, you have to sometimes just acknowledge what people are telling you, right? So a lot of people have really different beliefs than you do. Like, I have a patient who just like, she just doesn't believe in like any Western medicine. And sometimes I kind of want to be like, then why are you here? Right? Like, sometimes it's really frustrating because like she has a whole bunch of symptoms. She wants me to treat her, but then she won't listen to my advice. And I don't know what to tell her because, it's like, I know how I could solve your problem. And so with her, like at one point I kind of convinced her to do something, but then in the end she sort of decided to go around. Yeah, the one big thing of the reality of life is, in doing this job, is you realize that you can't control people. So sometimes it's sad, but you get over it. You then focus your attention on people that you can, right? It's just, yeah. Oh, my residency schedule was, I worked in a community hospital, so it was a little bit of a smaller hospital. I'm going back many years, and I feel like maybe I don't feel like my residency was horrible. I think if I was in a downtown hospital, it would have been much worse. I saw a lot of like bread and butter, just means like normal stuff, like this kind of like what I'm describing in this case kind of thing. I didn't see as much of the cool and wacky stuff, which you would see more in like a bigger hospital, but then you also have more responsibilities in those, right? You're usually on call like it depends on what specialty, right? Even within our city, right, there's so many different places where you do residency. Each program is different, right? So it's hard to kind of talk about it. When you were doing certain rotations, the hours sucked. Like when you're on orthopedics, like where they, all the stuff with bones and stuff, like you'd have to be there at like 7 o'clock in the morning, 6:45, 6:15 or 6, I don't know. I remember it was somewhere really early in the morning. When I was on my family medicine rotation, I'd have to get there at like 9. So varies, right? Someone's asking about how do you diagnose kids? Totally different topic in itself, but like you get an idea from like what the parents are telling you. And then also, you'd be surprised. The parents actually are pretty perceptive. So I actually do trust a lot of what parents tell me. And then your exam, right? Like, so your examination actually tells you a lot. That's questions about, I hope, like for anyone who's on WebShadowers, like I hope you're okay with me just like talking excessively. If you want me to stop where you guys have to go, I can stop, but I'm okay to answer more questions if you guys like that. In choosing a medical school in Canada, we don't really have a million choices. So, like I applied to 6 or 7, I can't remember, like all the ones that are in the, like you guys have states, we have provinces. So everyone that was in our province kind of thing. I got in, so I got an interview in my 3rd year of my undergrad, and I got waitlisted there and didn't get in. And then I got 2 interviews after my 4th year, one where I got in and one at McGill, which is like in Quebec. I got waitlisted there and I had to make a decision fast. So I just chose to stay where I was, kind of thing, right? But like, you know, I feel like in the States you want to be able to, yeah, the question is like the more places you apply to is like, then the more like, it's also more money involved in it. So I think you have to also, I feel like there's a lot more to sort of like consider in that too. I feel like, yeah, I forget. I mean, cosmetics is really interesting, like the exact opposite to what I do in this practice. And it's a little bit like artistic. So I feel like I wanted something on the side that was more like that required more like using my hands kind of thing rather than just talking to people all day. So I really like it. And I think there's really cool ways of improving people's appearance in a very natural way and also making people just feel better about themselves. So it actually, it's weird. You actually feel like you do help people, but in kind of in a different way. Yeah. I think people sometimes ask me, when did I choose family medicine? I think I realized relatively early on when I did my pediatrics rotation that like there's a lot of like genetic syndromes you have to know in pediatrics, and you see a lot of like really sick kids, or you know, like though like not every pediatrician does, you know, like hospital based, just like they can be like community based, like in a clinic just like me. But I just didn't like to see like a lot of really sick kids like with like cancer, and so, I don't know, it just wasn't my thing. So I was like, I realized I just liked kids, not necessarily like and I liked so I think I decided, I don't know, in my 2nd year, I think I kind of made that conclusion. Oh, someone's asking me about what made me choose family. Look, I feel like I've talked about family medicine like excessively, like everything about it. I work-life balance, being able to choose different things, like that kind of thing. I never saw myself as being a professor. In fact, like only recently have I had this profile online on Instagram that's where people have been kind of contacting me to do presentations. I don't really do that many presentations, though I do love doing them. Yeah, someone's asking about there's a 3-year program. Yeah. So like we have this emergency program, which fair enough. I don't know if in the States they may not actually accept it. I know that like even like going between Canada and the States, sometimes you have to do something different, right? And at the time, someone asking about being a PA, like there, if I remember right, I don't even know if there were PAs or there were that prevalent when I was going to school. Like now, like I think they're relatively new even here in Canada, so I don't even think I had a choice, to be honest. Yeah, so I definitely had a click moment. Yeah, so how I chose family medicine was I tried to find a specialty. Like I said, I wanted to be a specialist, and I tried a whole bunch of things, and I like shadowed people. That would be my biggest advice: shadow different doctors. And I just got bored and everything, and I did not get bored. Someone asked me about being a medical director. So in the cosmetic clinic I work at, I'm a medical director there. So basically just means that like, you know, should there be, it's a relatively big clinic. So if there's like issues in terms of like delegating tasks to nurses and this kind of stuff, protocols, this kind of stuff, I basically am involved in like creating a lot of those protocols, allowing like basically so the nurses have to have directives. Basically, they need to have like the ability to do certain procedures, and so like I basically, based on a consultation, agree whether or not someone is allowed to have certain procedures done. Yeah. Hospitals is a little bit different, right? Like personally, hospital was not my setting of choice, just because I feel like you can't ever really be off. Like, you know, you'll have a pager and this kind of thing. And you probably see, you know, depends on what kind of thing you're doing in the hospital, you might see less people who are admitted. So you're taking care of less people. But here I'm, you know, my day, like when I finish my day, like, you know, if someone has an emergency, they go to the hospital, right? Or we have an after hours clinic. So I don't have to really worry about like worrying about people after the fact, right? So.
Hello, Dr. Ramzan. Thank you so much for
You're
this.
welcome. Sorry, I'm like babbling on. If anyone has more questions, they can just email me or send me
I
a
was
message.
just gonna send out the Google form so then you can keep answering as many questions as you
Sure.
can.
I feel like I'd be on this forever talking. Not a problem. I'm really happy, and thank you so much for having me. I really appreciate it. Hope it was helpful.
It was so interactive and we all learned so much. Thank you.
You're welcome. Thank you so much. Have a great rest of the day.
Everyone, make sure you check out her socials. Her Instagram is at Hey Dr. Sarah. And thank you all for attending. The link to the Google form has now been posted, so please fill it out within the next 30 minutes for us to receive your verification of attendance.
It's
Again,
also
thank you so much.
Thank you.
Perfect. Have a great day, guys.